Hello everyone, welcome back to Hot Seat Season 3. I'm Omid Moghaddas joining you from Tehran, and once again I'm super excited to be with you all from this educational platform. And over the past seasons and over the past sessions, we had so many great speakers and educators from around the globe joining us and helping us obtaining better knowledge and understanding in treating our patient. And today, I have to say, I'm super excited because a very talented surgeon, a very talented implantologist is here with me, Dr. David Gonzales from Spain. First of all, I want to have to say, hello, David, and welcome, my friend, to Hot Seat, and thank you for accepting.
Thank you for inviting me. I'm glad to be here.
Thank you so much. The pleasure is all ours. And I'm pretty sure so many people are familiar with your work, but I have to say honestly, I'm a periodontist, and when you see some people's skills, it's mesmerizing, it's amazing. And you are one of those surgeons that I always look up to your work, and you show every details with the most beautiful skill that you have. And I'm so excited that you accepted the invitation and will present a spectacular presentation for all of us. And the topic that David gonna present for all of us today is about managing the defects after implant failures, or sometimes the need for three-dimensional augmentations that we should do for our patients for making it as beautiful as possible in our treatment protocols. So we will have amazing cases today during his presentation, and for sure, we will have a great discussion on the topic at the end of the presentation. But before we start, I would like to have a very short CV of David for all of you, and then we will go to the presentation and we'll enjoy every second of it, I'm pretty sure. Dr. David Gonzales has a doctorate degree in dentistry from Complutense University of Madrid with a distinction with honors, and the thesis was the risk factors in periodontal disease in 1999. He has a master's degree in periodontics, again from University of Madrid, and a specialty in implant dentistry. Also, he's associate professor in the master's degree in periodontics at the University of Barcelona. He is professor of the ongoing training courses in the illustrious General Council of Dentists and Stomatologists of Spain, author and co-author of more than 40 articles and presentations in national and international congresses and magazines from USA, from Sweden, Germany, Italy, Netherlands, United Kingdom, Ireland, Portugal. He's a super surgeon. He also has lectured in several courses around the globe and has an award for best communication in video format in the annual Congress of the Spanish Society of Periodontics and Osseointegration in Seville. Also, award for the best course of the year, Dentist Association of Zaragoza in 2010. There's so much more to tell, but I just wanted to have a short CV of you for our audience. And David, we are ready from head to toe to hear your beautiful presentation, my friend. You can share your screen and we will enjoy every second of it.
All right. Let me open the presentation for the hot seat. Let me take a look. English. All right. So share the screen. All right. Do you see my screen?
Yeah, I see your screen.
All right. Just let me. Okay, now you can see my screen.
Perfect.
Okay. First of all, I wanna thank Omid for inviting me. I'm very glad to be here. Actually, I'm very, very honored to be here. I don't think I deserve the kind words he said about me, but I will try to live up to it. So my topic will be about 3D bone regeneration, but I want to focus on the treatment of implant failure and show that in some cases we can do treatment of perimplantitis, or maybe in some cases we still have some palatal wall and reconstruct with simultaneous GBR. So I will show the decision tree for treating this kind of problems. So I want to start by saying that more than 25 years ago, we know that the implant in A position is fine, but the implant in the B position is wrong. So uh, the implant in the B position is prone to have mucositis, a gray color in the gingiva, and then after mucositis, perimplantitis. So we don't want to place our implants in the B form. We have now some literature that tell us that placing the implant in the wrong position is a risk factor for implant failure. We need to know that the implant has to be 4 millimeters from the gingival margin of the future crown, and it has to be aligned with the cingulum of the neighbor teeth. That's the right position of implants. And now we will say when we treat the implant and the condition factors for the treatment of failing implants. I think the key factor is the implant 3D position, the severity of perimplantitis, and the type of bone loss. It has to be vertical in order to be treated. And when we treat implant in the aesthetic zone, when we treat failing implant, we have to take into account that we may have soft tissue recession. We need to think about the stability of the regenerated bone. And we also have to consider that we may have scars, we may have potential infections of the graft. So we have to be very selective when to treat an implant that is failing, because sometimes we need to make a choice between regenerate or better do explantation in order to treat the failing implant. And when are we gonna regenerate? We're gonna try regeneration when we have three-dimensional optimal position, when we have integrity of the palatal and interproximal mucosa, when we have a vertical or circumferential moderate bone loss, and if we have palatal and interproximal bone peaks. And when do we explant the implant? When we have malposition of the implant, apical position of the interproximal or palatal bone peaks, severe or horizontal bone loss, and mucosa recession in the interproximal or in the palatal aspect. And according to the three-dimensional position, bone level of the implant, we will classify the implants in two big types: optimal position implant and malposition implant. If we have an implant in optimal position, we can do anti-effective and regenerative treatment. But if we have a malposition implant, especially an implant which is very buccal and very deep, we will extract the implant. And what will we do after extracting the implant? It depends. And in my opinion, the key factor is the maintenance of the palatal wall or the absence of the palatal wall. If we have palatal wall, we can do simultaneous GBR. But if we don't have palatal wall, we need to do 3D bone regeneration. And in some cases, we can use ridge augmentation. Now we want to speak about optimal position implant, and in which we can do anti-effective and regenerative treatment. Here we can see a case that was referred to me. It was a 20 woman with she had an abscess, a big abscess in the palatal area and some separation in the buccal area. And when we take the X-ray, we see that the implant is in good position, but we have a vertical bone loss, but the interproximal peaks are fine, and we still have some palatal bone. So it's a good position implant. The crown is cemented, and what we do was subgingival cleaning of the implant using curettes. And after 3 weeks, we're gonna do we're gonna make an implant surgery to detoxify the surface and try to regenerate the bone. We can see that after 3 weeks, after our scaling and root planing, or implant planing in this case, we control the inflammation. And then after raising a flap, an intracircular, intrapapillar flap, we can see cement remainings. The cement remainings, which I think it was the etiology of the problem, the first etiology, and then we have inflammation and bone loss. After cleaning the remainings of cement, we can see also the detoxifying of the implant surface using curettes and titanium toothbrush. We place over the implant some EDTA in order to detoxify. We also place a mix of metronidazole and amoxicillin in serum, saline serum. And then we harvested some bone from the neighbor area, and we filled the defect in the buccal and in the palatal aspect with the autogenous bone. And we use collagen membrane, and we place half the membrane in the buccal aspect and half the membrane in the palatal aspect. And then we reposition the flaps using mattress and interrupted sutures. This is the aspect 1 year later. In our opinion, the infection is totally controlled. The patient has not had any more inflammation, but we have a small recession. So we need to use a connective tissue graft in order to cover the gingival recession. And we use this kind of tunnel. I will go back. Use this incision in order to create a tunnel here. And we place this connective tissue graft, and we put the graft inside through this vertical incision using this mattress 6-0 sutures to place the graft in here. And then we make sling sutures in order to coronally reposition the whole soft tissue complex. And this is the final aspect 5 years later. We can see no more recession and that everything is corrected. We keep the papilla, and this is the lateral view. This is the final aspect 5 years later. This is the before and the after. So my advice is that when the implant is in good position, we can try to maintain the implant. Some of you may be saying, why do you keep the crown? This patient, the crown was not placed by me. This crown was placed 10 years before, when she was 18. And she actually, if I have to say the truth, she didn't have the money to change the crown. So now we'll go to the second type of implant. We saw the optimal position implant, and now we're going to see the malpositioned implant. And we will see a case that after extraction, we still have some palatal wall. This is a woman, 26-year-old. She had one implant, and we can see that the implant has a fistula in here, some bone loss. We can see that the implant is too buccal and too deep, and it's a one-part implant. I mean, it's an implant with the abutment included, a very famous brand of implant, and some cement remainings. I think that may be the cause, and also the malposition. And we managed to extract the implant using forceps. We were lucky, we didn't have to raise a flap. And after 3 months, we can see the mucosa healing. And now we're gonna assess the bone in order to see if we can place the implant simultaneously. So this is a Cbct where we can see that we still have a palatal bone wall. We're gonna need some bone graft, but we still have palatal wall. We raise a flap. This is the aspect of the bone. And we make the drilling. We drill the bone and we see this dehiscence. But we managed to place the implant in the right position for a screw-retained crown. But we can see that the dehiscence is in the total area of the implant. But my advice is that whenever you can place the implant in the optimal position, in the right direction, use simultaneous GBR. So we place the membrane. It's a PTFE membrane, and we used, in this case, only autogenous bone, which we harvested from the neighbor area. This is the membrane. This is a mattress suture in the palatal aspect, fixing the membrane, and in the buccal aspect, we place a couple of tacks. And this is the mattress sutures that over approach both flaps, the palatal and the buccal flaps, and then we place the 6-0 sutures. We use the principle by Professor Dahlin and the Gothenburg group of the late Professor Niemann about guided tissue regeneration using a membrane to exclude the entrance of fibroblasts in the defect. I am so lucky to be a friend and a student of Professor Dahlin. I consider him one of my mentors. He is the one that we can say had the idea of inventing the guided bone regeneration when he was a student of the doctorate program in Gothenburg under Professor Niemann's supervision. And some months later, we're gonna do the re-entry. And when we remove the membrane, remember it was a PTFE membrane, we can see this nice bone. And after removing the membrane, we place this connective tissue graft like a saddle, and we leave the graft submerged. And then only 1.5 months later, we're gonna do the second surgical phase to expose the implant, to uncover the implant, and we can see here the final crown. The implant is in the right position, the crown is screw retained, and we can see now the symmetry between both lateral incisors and the nice smile that these girls have, even with some papilla. The before and the after. This is the final aspect. And my advice is, when you can do it in the least traumatic way, use it. Because in this case, since I had palatal wall, I preferred to do it in one shot, simultaneous GBR. Now we're gonna see a malposition implant that has to be extracted, but we still have some palatal wall. We did this approach, simultaneous ridge augmentation, which we could publish in the International Journal of Aesthetic Dentistry last year, and I can show you the case. This is a woman, 29 years old. She had an implant for more than 10 years. You can see the same as the first case. The maxilla kept growing, and the crown looks kind of short. So now we have this problem. This was an implant, a very good brand of implant, but it was a very thick implant, 5 millimeters implant, and the implant was very deep and very thick and very buccal. And eventually, in time, she started losing mucosa until she had this problem. So now we can see the mucosa level, and also in the lateral incisor, we can see papilla loss and soft tissue recession in the lateral incisor. This is the aspect. We can see that the patient had no periodontitis, so it's an implant problem because the implant is too buccal, the implant in the right central incisor. But when we took the X-ray, we can see that here we still have some palatal wall. This is the smile of the girl. And first thing we did was removing the crown. We can see suppuration when removing the crown. And after removing the crown, we can see some calculus on the lateral incisor and the implant, which is very, very buccal. So now we only remove the calculus and place another abutment. We didn't remove the implant because we wanted to control the inflammation. And all we do is changing the crown here. We did a temporary bridge, acrylic resin bridge with a cantilever, but we have to consider that this crown is not connected to this abutment. It's only intact with abutment, but it's not connected. This is the aspect 2 months later, and 2 months later we had big recession of the papilla after removing the calculus in here. We still haven't raised any flap. Actually, we never did. And now it's time to remove the implant. So we remove the implant and we knew that we still have here the palatal wall. So we did this kind of experimental approach. Let's see. Here we can see the level of the palatal wall at the extraction site. And we can see that the left central incisor have a wrong gingival margin because it have altered passive eruption. So we need to do a crown lengthening here in the left central incisor. And we did this approach, which we did before when we do implants, immediate implants without buccal bone wall. But remember, here we still have the palatal wall. So we raise an envelope, a full thickness envelope, using a blunt instrument, about 8 millimeters on this area, from the mesial aspect of the central incisor to the mesial aspect of the lateral incisor, and we placed hydroxylapatite mixed with collagen, and we filled all the area with hydroxylapatite, and then we used a collagen membrane, and we placed the collagen membrane covering the whole xenograft, covering the whole ridge in the buccal and in the palatal aspect, like a saddle, covering everything without raising a flap. It's a very, very delicate, very tender surgery. And then when we have all the bone and all the membrane covering the bone, we harvested a soft tissue graft, connective tissue graft, and we covered the membrane with the connective tissue graft, so we can isolate the xenograft and membrane from the saliva, from the oral environment, by using this CTG. I will go back one slide. This is the mattress sutures in the buccal aspect and in the palatal aspect, because the CTG was very big to avoid necrosis. And here we can see the purple sutures, the mattress sutures in purple in the buccal and in the palatal aspect, and then 6-0 to avoid scars, invagination of the epithelium. So that's what we did. We placed the connective tissue, the xenograft. Remember, we still had the palatal wall. Even had the if I didn't have the palatal wall, I would have not treated this case this way. But I had the palatal wall, so I filled the ridge with the xenograft. Then I placed the membrane, and then I placed the connective tissue graft sealing. What I do here, this black line tries to resemble where the recessions. And this is the aspect 2 weeks later. We can see no signs of necrosis. And this is the aspect 10 months later. The patient has been very comfortable with this resin acrylic temporary, and I say I want to have at least 3 more months of healing, but let me do here something, because I want to have more soft tissue in here, and I want to try to correct this recession. So I remove the bridge. Remember, it's a temporary bridge. This root is very fine. And we can see here that this is the CEJ and this is the level of the palatal wall. So actually, it's the wall will be the implant will be 4 mm more apical than the final crown. So I will try to do a ridge augmentation here using connective tissue graft, but try not to disturb the bone graft healing. So I did this horizontal incision in the distal aspect of the lateral incisor, and using this microscalpel, I do here a partial split thickness flap or envelope, we can say. We enter through this incision, but also intrasulcular in the lateral incisor and in the central incisor, and we also have access until the palatal part of the ridge. And we harvested this big connective tissue graft from the previous area where we already had connective tissue in the first surgery 10 months before. So you can see here the fibrous and stronger aspect of this tissue. And we will put this graft inside the ridge by using these mattress sutures, which enter from the palatal aspect, and then through the incision, we do the mattress here, and we pulled the strings so we can place the CTG over the ridge, over the supracrestal area, like a saddle. And also we try to move the graft in the recession area, in the zenith of the lateral incisor. I have plenty of videos of all that I'm saying, so in a long course it can be possible to see step by step these kind of surgeries. So we placed the connective tissue graft, and we can see by doing nothing more that we already have gained some millimeters here, and that we have a thicker biotype in here. And then we place the bridge back on, and we do these sling sutures in order to have a more coronally positioned flap. This is the aspect 3 months later. Of course, we had some recession, but now it's time to evaluate what we already have. We can see that our procedure has gone very good, has gone very nice, that now we have a very stable material. Remember, it's been 13 months since the surgery, and now we can plan. We can see here that most of the xenograft is kind of resorbed, and now we have a nice ridge where we can place a 3.6 implant. And using a computer generated surgical guide, we can drill, and you can see even during the drilling, the pieces of bone. It's very nice to see in the video, in the drill, the bone inside the threads. And we place the implant. It's a 3.6 implant. And after placing the implant, we do immediate loading. So this is the aspect, after some healing, after we can say 2 or 3 months of healing, and we have, as we can see, this level is the same as this, but in my opinion, there's nothing more that I can do from a surgical point of view to gain more papilla. So it's time for my wife, who is an orthodontist, to pull this tooth, extrude this tooth, using the implant as anchor in the canine. And now we have a nice papilla from the same level here and here. We have symmetry between the papillas, but I think that I still can obtain a better emergence profile. So I remove the crown, and using a microscalpel, I do an envelope and place another connective tissue graft from the tuberosity. This is after placing the graft, and this is the sling suture, and this is the temporary crown after healing, and this is the final aspect. This crown, I have to say that were done by one of my friends and colleague, Ramon Garcia Dames, who did this nice crown, and this is over the implant. Of course, he changed the crown of the central incisor and did some composite restoration in the lateral incisor. So this is the lateral view. We can see the nice emergence profile. The implant, everything is healthy. The emergence profile, the before and the after. And this case was published in the International Journal of Aesthetic Dentistry last year, and it also appeared in the Japanese Journal of Aesthetic Dentistry this very year. And this is the final aspect. So we can see the before and the after. And now we have to speak about ridge augmentation when we don't have palatal bone wall. There are two techniques, in my opinion, to reconstruct the alveolar ridge when you extract an implant and you have a very, very big bone defect, especially when you lost the palatal wall. We have the GBR using non-resorbable membranes and the Curry's technique, kind of a casket. So now we're going to the final two cases of the presentation. I will start showing a case with the Curry's technique. This is a woman, 47 years old. She had a big trauma, and on the big trauma, she lost the left central incisor, and we can see that she also lost some of the periodontium of the neighbor teeth, and she had an infection in the crown, so the crown has to be removed and an abutment was placed. On the Cbct, we can see that the implant is inside the incisor canal. We can see here the healing abutment, and it's not connected to the crown because the crown had to be removed. And now we remove the Maryland bridge that she had, and we managed to go inside and find the implant without raising a flap. And we removed the implant. And this is the aspect 3 months later. Remember, we haven't raised any flap in here, and we have a big recession on the central and in the lateral incisor. No emergence profile. We have a very, very flat ridge. And we have this defect, which is in connection with the incisor canal. So now we're gonna do the surgery we need to do. We're gonna plan the surgery. We see that we don't have any palatal wall at all. We lost the whole palatal bone wall. And I will do my surgery and I always do supracrestal incision. Why? Because if we see the anatomy, the palatal flap will be always irrigated by the palatal vessels, and the buccal flap will be always irrigated by the buccal vessels. So if we do this, in my opinion, we will not have irrigation, a blood supply problem. And we also have a very nice access to all the defects. So after raising the flap, a full thickness flap with the supracrestal incision, we can see that we have no palatal bone wall at all. And we also have alveolar dehiscence on the lateral and in the central incisor. So this is the defect, and the challenge for me is not only the bone defect, but also the periodontal defects that are on the neighbor teeth. And remember this in connection with the incisor canal. So we're gonna do the Coolridge technique, split bone block, cortical block technique, and we go to the external oblique line by raising a trapezoid flap, taking not to hurt the mental foramen. And when we harvest the block, we have to remove this bone marrow, and we can see here the big size of the block. Okay, I have to say that I was lucky that the patient had the material, because it's not up to me. It depends on what the patient have. So after cutting the block, we place one side of the block in the buccal aspect and another part of the block in the palatal aspect. I don't like to unite both blocks with the same screw, because for me it's better to put it individually. And after placing the blocks, I fill everything using scraped bone. I obtain this bone with a bone safe scraper, and we can see the level of the bone in here, because it will act as a tent pole in here, so we can see if it's possible to cover some of the root. And then I always place this coronal block, because I like to cover my bone in here. I know some people don't do this, but I like it. Then we can discuss why I do this. And this is the final view of the surgery, the buccal view, and the incisor view, where we can see buccal, coronal, and palatal blocks. And after releasing incisions on the periosteum, we put these mattress sutures in order to over approach both flaps, and then interrupted sutures. And this is the donor area and the recipient area. This is the aspect 6 months later. I wait longer because we all know that in 4 months we can go back in, but I preferred to wait a little longer in order to have a more mature bone. And this is the Cbct that I take before doing my surgery. We can see here the buccal block, the very radiopaque aspect of the new bone, and the palatal block in here. And now we will see the Cbct. I see the buccal aspect, and what I like better of this case is seeing the palatal block, which is completely sealing the defect. So I can make sure that everything is sealed in here. So I raise a new flap, and we can see the new bone is totally healed, is mature, it's very bright, I can say. And we can see that we also obtained some bone cover, we may say, of the roots. We don't know if it's new insertion or ankylosing or whatever, but actually I'm happy because the alveolar dehiscence of the root big as before. So we can say we covered something. And this is the incisal view. So then we remove the screws and we will drill in order to place an implant. We placed this implant and we harvest a CTG from the palate in order to have some more soft tissue, and we submerged the mucosa, the connective tissue graft. And this is the aspect 3 later. We have no keratinized tissue at all, but we managed to do the second surgical phase in order to uncover the implant and place a healing abutment. And this is the temporary crown. And now, because we don't have, I will go back, sorry. Since we don't have any keratinized tissue, we need to reposition the mucogingival line. Actually, we need to create a keratinized tissue here. And we do this split thickness flap, and then we place this connective tissue graft. We fix the graft using these sutures, interrupted sutures, and now we have some vestibule in here, and due to the malposition of the other teeth, we do some orthodontic treatment in order to straighten this tooth, the central and the lateral incisor, and intrude a little the right lateral incisor. And this is after fast orthodontic treatment on to align those teeth. And now we go for a second temporary crown. And then after some healing of the second temporary crown, we go for the final crown. We can see now the nice emergence profile, the nice aspect of the emergence profile. And this is the final crown, an implant, a screw retained supported crown. This is the lateral view. This is the frontal view, the incisal view, and it's a screw retained crown. Of course, we needed some composite restoration on the lateral, on the neighbor teeth, but remember the before and the after. Remember the bad situation we had on the neighbor teeth. So this is the before and the after. We reconstruct not only the bone, but also the soft tissue. And in the lateral view, we also can see the nice emergence profile we have now. This is the periapical X-ray, the panoramic X-ray, the before and the after, with the Curry's technique, split bone block technique. And this is the final aspect. Now it's going fine. The patient come every year to maintenance, and it's been very, very stable and good so far. Now I will present the final case. It's a case that we also that we didn't have any palatal bone wall, and we needed to do 3D bone regeneration. And for this case, we used the GBR, which means using a membrane. Let me present this case. This was a case where 2 implants were removed, were extracted, because this patient had a big infection and the implant had to be removed. The patient told me that the infection was such a big infection that he had a fistula, and when the implant were extracted, he had suppuration through the nose and through the mouth, and it has to be operated on the sinus by ORL through the ostium and heal the sinus, but we can see the big defect that we have. So after second intention healing, we can see, let's take a look of the area. Here, there was an oral sinus fistula, and the fistula healed after cleaning the sinus by second intention. And we can see here kind of a marsupial pocket in the where the fistula path were through, and it's about 4 or 5 millimeters the marsupial pocket. And in my opinion, it's a very, very tough case. Why? Because here we have a bad quality mucosa, not good keratinization, and we lost the papilla in the central incisor, and from the buccal aspect, we can see the palatal mucosa. So in my opinion, it's a very, very tough case. We can see the problems in the yellow arrows. But no matter the difficulty of the case, we do the same approach. We managed to do a supracrestal incision, but we have to be clever. We have to angle the tip of the scalpel away from the marsupial pocket path, and after carefully raising a flap, we can see that huge defect in, I remember it was 23 millimeters vertical component, and in order to seal the sinus here, because in the apical part of the defect there was a sinus lesion. Remember, there was a fistula there. We place a collagen sponge. It's not collagen bone. It's a collagen sponge. No xenografting here. Only collagen sponge to isolate the sinus from the defect. And then here we can see the collagen sponge. And then we place this membrane. This is a TFE membrane. We fix the membrane by using mattress sutures to the palatal flap. and we go to the chin and we harvest all this autogenous bone. This case was done 100% autogenous bone, and we had to place another membrane. Why? Because the defect was too big, and here we didn't have enough with one only membrane. So we had to fix this membrane using these mattress sutures, resorbable mattress sutures to the palatal aspect. Here you can see, and then we place another membrane in the buccal aspect, and we bind this membrane by using, we suture this membrane together by using mattress sutures. This is in the yellow arrows, we can see the PTFE sutures 5-0, suturing the membrane, fixing the membrane to the palatal aspect. And these are the purple are for fixing the membrane in the supracrestal area. And then I will go back in the buccal aspect, we place these tags. And these are to suture both membranes. So then after incisions on the periosteum, I place these 6-0 sutures, monofilament, and every papilla goes to the right position. I don't shift any papilla, all goes to the right position. But we have to be clever not to communicate with the marsupial pocket in here. This is the chin after the graft. 2 weeks later, we remove all the stitches. These sutures, the deep palatal sutures that fix the membrane are very hard to remove because they incarnate in the palate mucosa. And this is the aspect 1 year later. I let it heal for 1 year. The patient has worn this Maryland bridge during all the year. And this is the aspect. We can see that we have gained some papilla in here. And now we will see the restoration. The restoration is planned using digital scanner. My restorative colleague kind of copied the other canine lateral incisor, and we planned to place a big implant in the canine area. The lateral will be a cantilever. And on this cut, we can see here in this section how the implant will be totally surrounded by new bone, plenty of bone. And now we go for the implant placement and removal of the membrane surgery. We raise a flap, we remove the membranes. Remember, and there were 2 membranes. And after removing the membrane, you always see this very, very thin soft tissue. It's only less than 0.5 millimeter. If you want to see the literature about it, is Professor Dalin said that it's kind of a periosteum. So we actually don't remove it. We know it's only less than 0.5 millimeter. And we use this surgical guide to place the canine in the right position. After in the drilling, it's beautiful to see in the video when we are drilling and we obtain in between the thread this nice bone. And we managed to place this implant. Is a 4.5, 15 millimeters implant. And we can see the implant in the right position for the canine. Remember, the lateral will be a cantilever. And since we always want some more tissue, We go to the maxillary tuberosity and we get the whole tuberosity. We remove the epithelium. And on this view is very important that you can see the cortical aspect around the implant. It's totally cortical. That's why I don't remove this very thin layer, because I know under it there's always a big cortical bone, and I let it like that in order to protect this nice bone. So we use this connective tissue graft on the tuberosity, and we place it like a saddle in order to obtain more soft tissue height. And 2 months later, after placing the implant, when we consider that the tuberosity maxillary connective tissue graft is already healed, we go for the second, for the reposition of the mucogingival line. Remember, we have displaced coronally the mucogingival line, so we're gonna put it back at the position. So we raised this split thickness flap. We suture the flap in the apical area, and here we're gonna place a connective tissue graft like that with using inverted suture. And this is the final view. We can see we obtained the graft. We harvested the graft on this side and we put it on this side. And this is the aspect 1 month later. So it's been a total of 3 months after placing the implant. When we do the second surgical phase, we go with this hollover to go for the implant. And when we locate the implant, we place this temporary prosthesis. This is the aspect after no more than an hour of placing the temporary restoration. This is a lateral view of the temporary restoration. And this is the final restoration, which we place some months later. It's a screw retained restoration, zirconia porcelain restoration here. And this is the final aspect. You can see the nice papilla in the distal aspect of the central incisor. This is the bone. For me, this is very important. See that the bone is totally maintained, and the aspect of the bone is completely natural, radiopaque. This is a lateral view. We can see here the nice papilla on the distal area of the central incisor, and in the mesh area of the premolar. But between the implant and the cantilever, the papilla is a little shorter because there's no periodontal ligament. This is the screw retained prosthesis, and this is the aspect of the graft, which is very similar to the natural mucosa, natural gingiva. So remember the before, and this is the after. And if we know the literature, we know that this is only a less than 0.5 millimeter layer of soft tissue, like a periosteum. So I don't want to remove it. Professor Christel Dalin, which is maybe the person that knows more about bone in the whole world, say that don't remove it. So I obey. This is the before and the after. It was a 23 millimeters vertical component defect, and it's a complete regeneration using 100% autogenous bone, PTFE titanium reinforced membrane. Remember the starting point. Remember no keratous tissue, marsupial pocket. You can see here palatal mucosa from the vocal aspect. So it's a case which is totally inconvenient. And my advice is go for the supracrestal incision, because if you know how to manage the soft tissue, you will have nobody can say 100% success, but you will be successful more than 95%, because it's a very predictable technique. And this is the final result. The final result. This is a video that the patient allowed me to take, so we can see that everything is the real thing. He's a professor of physics, so he knows about the scientific literature, and he allowed me to take this video. The final result. Everything is described on my book, but this book is in Spanish. It's from the editorial Quintessence. It's a plastic and regenerative surgical implantology on the aesthetic zone. And this is my conclusion. My conclusion is, if the implant is in optimal position, and the defect is vertical, you can go for regenerative, anti-infective integration, regenerative treatment. But if the implant is in bad position, in malposition, you have to extract the implant, especially if it's very deep and very vocal. If you have palatal wall, do simultaneous GBR. If you don't have palatal wall, go for 3D bone regeneration, either 3D GBR using membrane or Curry's technique. And only in experimental cases you can do simultaneous ridge augmentation. So my steps of implantation, of implant extraction, is clinical diagnosis. Don't forget your periodontal probe, periapical X-ray, Cbct, ultramatic extraction. Only if it's possible, very few cases it's possible, simultaneous reconstruction, clinical reassessment if you extract the implant, periapical X-ray and Cbct 3-4 months later. Bone regeneration, if you still have palatal bone wall, do it simultaneous if possible. I like to do GBR with membrane. I only use Curry's technique when I don't have palatal wall, and I do three-dimensional reconstruction. We can see 8 hours if you want of Curry's technique, but all of the cases are cases with no palatal wall. If I have palatal wall, I think of my patient, and I think that it is less traumatic and quicker and very predictable to do simultaneous GBR, either using resorbable or not resorbable membrane. There's plenty of literature about it. And finally, change the prosthesis. So thank you very much to all of you, and especially to my friend Omid, Dr. Omid Moghaddas, for inviting me to this presentation. It's been an honor for me to speak for such a nice group. Thank you very much. Omid.
Thank you so much.
How long did it take?
If what?
I can see that I took longer.
No, it was, David, I have to tell you, as I said at the beginning, your cases are, wow, just amazing. The way that you just handled those cases, as you said, the best part I liked about it is that all these cases can be predictably treated with good techniques. And I think it's a very good message to lots of practitioners around the world, because some people really don't believe in building bone in that amount. And especially those two last cases that you showed, they were just amazing. You know, what you did was amazing.
Thank you.
I have to
Thank you. My advice, my message I wanted was not only to operate on a patient, but seeing the case, make a diagnosis, and treat. If you can save the implant, save the implant. But if it's not possible, if the implant is in bad position, like very labial or deep, go for the implant, extract the implant, and then make the reconstruction. And when it's time to the reconstruction, I mean 3 months later, so the mucosa is totally keratinized. Don't go for I will go for Curry's technique on mandatory. I don't think so. I think that if you can do it simultaneous with a more easy technique, go for the easy technique. You have to think of your for the patient. You have to think that the patient can be your relative, can be your mother, your wife, or if you have some age, can be even your son or your daughter. So you will treat the patient like a relative, like a familiar. And that's why I show these many cases. I didn't want to go for the 3D bone regeneration, which is very cool and very appealing. But I wanted to show other ways. And I say, if you want to see Curry's cases, we can spend a whole day seeing cases, videos, the technique, etc. But I want to use it when it's indicated.
Yeah, David, I have a question regarding the Khoury technique that you presented. In your case, the central and the lateral incisor, as I remember, had a very little interproximal, especially the central incisor. And I want to know, in those cases that the proximal root is exposed, how do you manage to fix your plates, and how predictable is to build bone on the exposed root surface?
What I do on this case is I can do this case if I know that I have a big block, because it's not possible to fix the block to the neighbor teeth. So I have to fix the block to the apical part of the bone. The block will be almost in contact with the root, but it will not touch the root, because if I touch the root, I can have an exposure of the or adhesions of the flap. So I have to take a big bone graft and I have to fix the block in the apical aspect, either in palatal or in buccal area. And you can see that it has the aspect of a tent pole, because in the incisor view, you see that the buccal block is more buccal than the roots of the neighbor teeth. So after placing and fixing very well the blocks, you manage to condense a lot of bone inside the box that you are building and over the roots. And I think that if you compact, if you condense the bone very, very tight, and you have the buccal block in a more buccal position, you will have the effect of tempo. How predictable is it? I really don't know. Sometimes you get it, sometimes you don't. You may not think that it will be 100% predictable. Actually, I have cases, maybe you have seen cases in other populations where the whole root is totally restored in the buccal, in the interproximal aspect. In this case, it was kind of, I think, 70%, something like that. So I don't think it's totally predictable to cover the root, but you can have a nice result. So our goal has to be the defect, the interdental defect. If we manage to cover the buccal part of the roots, it's fine. But I don't obsess with that. My obsession is the bone defect where we will place the implant.
Yeah. And you know, you talked about the piece of bone that you prefer to place on top. You know, some people only put the buccal and palatal, but you also place one on top. What is your rationale for that, and why do you prefer that?
Okay, I will tell you. I remember in 2009 when I went to Olsberg with to see the technique in the clinic of Professor Curry. I went 2 times. I did his courses, which was going 2 times to see the operations, and I saw that sometimes they place the final block, the coronal block, and sometimes they don't. And it depends on if they have it, they put it. If they didn't have it, they didn't put it. And when I started doing the technique, I looked for the easiest way, which is not place anything on top. But when I did the re-entry 4 months later, I didn't like the quality of the coronal bone. I didn't like it. I know it's controversial, what I will say. I know it's controversial because you're supposed not to need that final block and you will have nice bone. But in my hands, in my experience, I didn't like the first 2 millimeters of that bone. When I opened and I scratched, I scraped that bone was soft. It was kind of osteo. And I said to myself, I will place the final block wherever it takes. And from that moment, I only needed 3 cases, no more, to see that I didn't like that bone. So I always place the final coronal block. I know it's controversial. I know there are big opinions leaders who will say that it's not necessary. In my opinion, in my humble opinion, it's necessary.
Yeah, the quality was better. And you know, you also showed amazing case by non-resorbable membranes. And what was really interesting for me was that you fixed the membranes with sutures to the palatal flap. Are you not worried about the movement of the membrane? Do you prefer sutures to tags, or it depends on some specific criteria?
No. I always 100% of my cases fix the membrane using PTFE sutures in the palatal aspect, only in the palatal aspect. In the buccal aspect, I always go for the tags. But in the palatal aspect, since the palatal flap is very, very strong, it's very strong, very thick, and very thick, that's the word, and very strong and very stable, I go for the mattress sutures. I've been doing this for the last 20 years, and in my opinion, is the easiest and cheapest and fastest and less traumatic way to fix the membrane. Because if you want to place a tack inside, even if you use a triangle in the palate, you have to raise a flap, a bigger flap. But if you use the tissues, you don't have to raise a flap. You only have to expose the palatal aspect of the defect, go with the needle and pull the membrane inside. So it's very predictable, and is, in my opinion, easier, faster, less traumatic, and predictable. And after 2 weeks, in my experience, there's no movement of the membrane. I have plenty of cases of Cbct before moving the membrane a year later or 9 months later, and you can see of course, you cannot see the PTA. What you see is the titanium armor, the titanium, you see it in the right position. So I'm not afraid of moving the membrane. After 2 weeks, the membrane is stable. And we have.
Sorry, I noticed also that you used, I think it was resorbable suture that you use in the proximal area around the tooth to fix the membrane from adjacent parts.
Yes, Omid, but this is kind of a trick. This is kind of a trick because the membrane, the defect was too big for one only membrane, even if those membranes are very big. Right now, a few months ago, we have a 50 millimeters membrane. So maybe we don't need to do those very difficult surgeries no more, because with the 50 millimeters membrane, maybe what we cover the whole defect, or if we need some more membrane, we will only need a small piece of membrane, and we can manage to place tacks in the, to take the membrane from the palatal to the buccal area and place a couple of tacks in the buccal area, and then the little that need more, place another membrane. So that very difficult trick of using resorbable membrane in the interproximal aspect, in the distal aspect of the neighbor teeth, will not be necessary, I hope, no more. Yeah. Because now we have longer, big membranes.
And I think one of the great points that you showed in your presentation was orthodontics played a very important role in final results, because some people don't pay enough attention to orthodontics and what it can do in bringing tissues and make the aesthetic outcome the best way possible. And that was really interesting that you showed in most of your cases that orthodontics was a part of your treatment in achieving the best outcome.
Yes, because for example, in the case that was published in the International Journal of Aesthetic Dentistry, there was a point where I couldn't do any more in the surgical aspect. I needed papilla, and there was no possibility, even if we do a tunnel, even if we do, what we can do is maybe even have a necrosis or even worsen the case. But it's so easy for the orthodontist to extrude very slowly, and half a millimeter a month, half a millimeter, and in some months they have the papilla in the right position, and they don't harm the patient. And for the orthodontist, it's the easiest move to do the extrusion. So we have to consider in our treatment in the aesthetic area, the orthodontic treatment. And in my case, my wife is an orthodontist. so she has to work.
And you know, David, I have one last question for you. Actually, it's my own question, and I think it will be interesting. You know, in some patients, we have the cleft of the palate. So the defect
Yes.
going to the mucosa underneath. You know, we don't have any apical bone. It's all mucosa down the road, you know. In such cases, if we want to do the reconstruction, do you prefer to put a plate at the bottom of the defect so to prevent the tissue to come coronally? Or what is your approach in those cases if you have the palatal cleft and the apical part of the defect is all soft tissue?
Okay, okay, let me answer. Let me answer, and I don't know if you know this history. The Curry's technique was not, I will say it right. I will look for the word. Dr. Tessier was a maxillofacial surgeon of France, a French maxillofacial surgeon. And he invented what we call the Curry's technique is kind of an implantology used for the tertiary graft technique to treat the palate. You know what I mean? What I mean is that the origin of the Curry's technique was invented. The principles were Professor Tessier, who was a French maxillofacial surgeon. And it was from the area to seal the palate. So I think that what we call the Curry's technique, which some maxillofacial call the Tessier technique to close the palatal cleft, can be used on this case, but I am a periodontologist. I don't, if I have to this kind of surgeries, I prefer to refer such cases to the maxillofacial surgeon who do the Curry's technique using the Tessier approach, which is the Calvaria.
Yeah, I got it. It just came to my mind.
Did I explain myself?
Yeah, you know, it just came to my mind, so I wanted to know your idea about it, and that was interesting that you said the story about it, because sometimes we face such defects, and it may be a question for some people that how to seal the soft tissue in the apical part. And it just came to my mind that maybe we can use that plate in the apical part and then graft on top of it. And as you said, it was it's definitely an amazing.
No, but if the defect is because of an implant removal, I think the surgery can be done for us. But if we have a palatal cleft, the whole palatal cleft, I think that has to be done by a maxillofacial surgeon. So, in your question, I think our limit has to be if we have integrity of the palatal area, or we can say the palatal dome. But if we have the whole palatal cleft, I will refer the case to the maxillofacial surgeon. So if it's located on the central incisor and it's in contact with the nose mucosa, I think we can solve it by placing a very small block in top in the apical part. I think it's in our limit, but I understood that you were saying in the whole palatal cleft. And the Tessier reference, I think Tessier did this approach in 20,000 patients.
Wow.
20,000 patients. So maybe we should consider saying the Tessier's technique.
Yeah.
Because he's the father of this concept. Although Professor Curry, who I feel a lot of respect for, did this approach on the maxilla for the implants.
Exactly. Exactly. David, I truly have to thank you again so much. I really enjoyed talking with you and seeing your beautiful cases. You know, I think we can talk about these cases for hours and hours and hours, but I know your time is also limited. So I just want to thank you so much. I really looking forward to see you very soon and hopefully in Tehran soon. But hats off, my friend. Thank you so much.
Anytime, my friend. Anytime. I will be honored and I will be glad to go there with you to your beautiful country.
Thank you so much. Take care.
Thank you.
Stay safe. Hope to see you very soon. God bless you.
Okay. Goodbye. Bye. Thank you.